Good morning, friends. I'm Dr. Mohan Rajan here, and we have Dr. Ravi Kumar Reddy and also Dr. Sudhir here. And Ravindra, please come. Yeah. And this session is a very important session because phacoemulsification and IOL, what you must know, is very important. I think I wish there are more delegates because it will be a very useful session for all of us, starting from the basics. And we have Ishwar here, and he's going to talk to us on preoperative investigations in a case of cataract. 7-minute talk, okay?
Good morning, everyone. I'm Dr. Ishwar from Sushila Netralaya, Karnool. I thank AOS for giving me this opportunity to present. And my talk is on preoperative investigations in case of cataract, and there are no financial interest. I am dividing this topic into two parts, systemic investigations and ocular investigations. Coming to systemic investigations, for the routine investigations, we do viral markers, RBS, blood sugar, blood pressure, ECG, and Xerocan sensitivity test. Viral markers are very important because it has been seen that so many instruments we use are going to get contaminated with the viral particles when we do surgery on a patient having these problems, and it has to be done because to protect ourselves for the healthcare workers to prevent these diseases. And coming to blood sugar, AIOS guidelines are around RBS less than 200 milligrams per deciliter is the most important thing. For AIO guidelines, it has been said that FBS 90 to 130 milligrams and PPBS less than 190 as a consideration for blood sugar. Why blood sugar is important? Because we know if the patient is having hyperglycemia, they may have wound infections and the wound closure will also be delayed and it may be very problematic. And blood pressure is very important because if the patient is having hypertension on table, he may land up in any complications like cardiovascular events and neurovascular events. So checking blood pressure on before surgery and before in the preoperative itself is very important. If the patient is having less than 180 by 110, it is considered as better option. We can go with the elective surgery. If it is more than 180 by 110, it's better not to do the surgery and control the blood pressure and do the surgery. And ECG should be done when the patient is having symptoms according to cardiac history, and ECG, echo should be done when the patient is having cardiac history, and there is no need for routinely doing for cataract surgery. Xerocan sensitivity test is very, very important because if we do inject for peribulbar block, if the patient lands up in anaphylactic shock, it is very drastic emergency thing. We should give immediate response to treat the patient. So doing Xerocan sensitivity test before surgery is most important. We must inject 0.2 ml of Xerocan with hyaluronidase because even hyaluronidase having allergy to so many patients, so we have to give better hyaluronidase and lignocaine half an hour before. Okay, for pre-senile cataracts, it's in the OPD settings. We must check about serum, vitamin D, dyslipidemia, and smoking history. It will tell us about if the patient is having any cardiac, any other symptoms also. Complicated cataract, there is some complete so many investigations that should be done so that we can protect the retina as well as systemically, so that we have to give the systemic treatment or just ocular treatment is enough or not. Congenital cataract, the patient may be having any CNS issues, CVS issues, systemic issues, so better to do all this battery of tests so that it's better to help them systemically also. Ocular investigations, these are the tests I'm going to talk about. And coming to syringing, Roplas is the thing which we can do in the OPD. Lacrimal syringing is very must because the patient may land up in endophthalmitis if we don't do the lacrimal syringing. It's a drastic complication any cataract surgeon can expect. So meibography is very important because we see where the ocular surface is not good, the patient may land up in refractive surprises and the patient may not be happy also post-operatively because of the dry eye symptoms will increase more after the cataract surgery. And if we can see over here, the keratometer readings are, we can see in the map also, there are some abnormality in the anterior surface when the IOL power is 20, but when we treat the patient for dry eye, we may land up in refractive surprise also. The IOL power is 21. So the Phaco study has told that it's better to treat the ocular surface beforehand, before going to cataract surgery, then we don't land up in refractive surprise and patient will also be happy. And keratometry is most important by doing tomography and topography because we can measure the astigmatism. Depending upon the astigmatism, we can go to the toric IOLs, and if the patient is having corneal ectasias, which may not find out through slit lamp, if may be in hurry or something like that, even with slight differences in the corneal ectasia can be treated by doing the tomography. And post-refractive surgery, if you do Post-refractive surgery IOL formulas will be different compared to normal things. Sometimes patient may be not telling in the history, but we can identify it by seeing the tomography. And corneal higher order aberrations must be checked, because if the corneal higher order aberrations are not checked, the patient might have less contrast sensitivity, and they should not be having, they must be having a lot of glare and halos. So we must not go for multifocals and toric IOLs or EDOF lenses when the patient is having high corneal astigmat, higher order aberrations. And by seeing the topographic pattern, we can identify the refractive surgery the patient had, and if the patient is having corneal spherical aberrations positive, if negative corneal spherical aberrations, we can go with spherical IOLs, and vice versa. If the corneal spherical aberrations are positive, we can go with aspheric IOLs, and depending upon the corneal astigmatism, we can go with the toric IOLs. Specular microscopy is also an important tool to be done beforehand, because we may identify any corneal issue, endothelial issue is there not. Either we have to go directly with the cataract surgery, or we may have to do endothelial keratoplasty along with cataract surgery. Ultrasound biometry is most important in calculating the IOL formulas. Previously, ultrasound biometry is used. Immersion scan is much better than the contact scan, and optical biometry is better than the ultrasound biometry. And these are the tools which we use daily for optical biometry: subsource OCT, partial coherence interferometry, low coherence optical reflectometer. And it has been said that compared to others, subsource OCT is much better compared to partial coherence interferometry and other things. And these are the IOL formulas which we use, and the recent AO guidelines is saying that Kane, Olsen, and Barrett are the best for any type of cataract surgery or eye, so that we can get the better outcomes. B-scan is must when it is a dense cataract with too much PSC or mature cataracts, we can't see opaque media. Like in this case, we can identify RD, we can identify the posterior staphyloma, we can identify the intraocular foreign bodies, and it's in a case of dense vitreous hemorrhage, and it's in case of posterior vitreous detachment. These things can be identified much beforehand. We can give the prognosis to the patient. And optical coherence tomography is much more important in daily scenarios, because the expectations of the patients are too high. We may land up in visual surprises if the patient is not identified correctly. The patient may be having so many macular problems because of cataract. We may not be seeing those properly also. In this case, VMT is there. In this case, we can see diabetic proliferative retinopathy and central serous retinopathy, or we can see like macular telangiectasia, where the patient might be landing up in sub vision. So patient may be not happy after surgery. So we must rule out these things. As a take-home message, I want to say, patient expectations are at an all-time high. If you miss a problem beforehand, patient will assume that surgery is wrong, and surgeon might have done something wrong. And we must check everything so that we don't have refractive surprises, and we must check the macula, better option, so that we don't land up in visual surprises. And we should not withhold the OCT until something looks wrong at the slit lamp. Thank you, AIS, for giving me this opportunity.
Excellent presentation, Dr. Ishwar. I have some queries regarding the blood sugar. How much should be the blood sugar before we operate? You have given the guideline of fasting blood less than 140. Yes, even some endocrinologists recommend if it is less than 200, you can operate. I want the panel to speak about it.
We do follow same fasting 140, post lunch less than 200, not 180.
Suppose blood sugar is 160 or 170.
Yeah, we can operate, sir. And
feel.
look at the HbA1c also. If the HbA1c is way high, about 11 or 12, probably you should not, because it means that at that time when you take the blood sugar will be 170. But if you take the 3 months average, you may be 11, 12. It's not a very good thing. So probably need to reduce it to about 7 or 8, and then.
No, I mean that 140 blood sugar strict. We should
No,
not.
it's not strict. It's not strict.
It is not.
Less than 200 is the guideline.
One time blood sugar is not.
Suppose it is 160 or 170 or 180.
You can operate, sir.
You can operate. Less than 200, I feel.
Less than 200 RBS is the better option. As a guideline, we
There is
do
no
routinely.
cut-off level
There
like
is
that.
no cut-off level in it.
Yeah.
Second query I have regarding the syringing part. Is it mandatory to do syringing in all
So it's a risk
patients?
factor for endophthalmitis. Sometimes we miss the RO plus, so it's better option to do syringing.
Suppose
for
RO
all.
plus is negative and you feel
No, I do agree. I have done so many DCTs recently also.
Yes, sir.
So if the syringing is negative and the patient says only watering, no discharge, I opened the sac and sent for culture, positive.
Absolutely, sir.
Syringing is a must. If it is a negative, DCT is a must.
Yeah.
So otherwise, legally you have a problem. And I also, practically also, I have demonstrated there is an infection in the sac. The other thing I want to know from the panelist is the Gelacan test is a must for all?
Not necessary, sir.
Not necessary.
Not necessarily, I don't do it, but.
I don't do it.
Yeah, I also
We,
don't
we
it.
do
Because
a
there's no-
large volume.
Yeah, I don't,
We have to see how much is the anaphylaxis rate. I
No.
think it's 1 in
2%.
20,000.
yeah, no, no,
One in
even then there is no this thing, sir, even the Xeralcan test is positive, we do
There
not
is
know.
no
Yeah,
guarantee.
there's no guarantee. So, but the
If
syringing
it
is
is
something
negative
which.
also no guarantee.
Yeah, whenever, see, please understand, when you see a patient with discharge in the medial canthus, or there is a MGD, or excess of watering, those patients, I think you should do syringing. But only thing is, don't do syringing on the day before surgery.
On
Okay?
the day of surgery.
On the day of surgery or one day before surgery
Day
also.
before is okay. On the
One-
day of surgery, no.
Normally we don't do, sir. When they come for a checkup, you do the syringing. So it's very important. Droplas is okay, but when you suspect and 1-8 patients, all that, we do a swab as well as syringing as well. Anyway, there are a lot of different ways to skin the cat. I think we should go on, sir, because next speaker is ready.
Thank you.
Ravindra.
Next speaker is the
Well done,
Dr.
Ishwar.
Ravindra. The parameter matrices in phacoemulsification. The surgeon's nerve versus machine nerve.
Yes.
Hello. I thank the AIOS for the great opportunity for sharing my experience. It is very important for us to understand that the machine has to be good, but at the same time, the surgeon has to be able to understand the machine. Once we understand the machine, we can take the best out of the machine. I will try to demonstrate my experiences with one of the techniques that I invented. So the optimization of the parameters and the surgeon's thought processes. This is a matrix. On one side, there are the Phaco mode, flow, vacuum, IOP, foot pedal modulations. And on the other side are what we have selected, whether it is continuous or pulse or burst, linear or fixed, and whether the IOP we have set is at high, moderate or low, and whether we have asked for a linearity with a particular type of steepness. And within each surgery, there will be options, divide and conquer, stop and chop, or chip and flip, and the steps could be grooving, cracking, holding for quadrant removal. And these things will, each step will have a particular set of parameters that are optimum. We could do the whole surgery procedure with the same set of parameters, but it will always be good to have optimization for each step rather than for the procedure. Twister chop is something that I started doing, and
achieved. Case number 1.
it is a bent chopper. The ideal is a bent chopper for this, not the straight chopper. Straight, I mean Phaco tip. In the inset video, we are seeing the hand and movements of the hand. I will be zooming at a later stage of this. So holding with the tip is important to create the vacuum. And while cracking and separation is occurring, we have to maintain the vacuum. So how do we maintain the vacuum is by maintaining the foot pedal position at a particular level. within the holding step, we have to initiate the aspiration, see the rise in vacuum, and then we have to be able to hold it. And within the cracking, we have to bring the left hand into play, we have to bring the right hand into play, and then we are to crack and separate. So for all these steps, the flow is important, the vacuum is important, and overall the right balance of phaco is required. And then the reflexive nature of the surgeon's action, how the surgeon controls the flow rate and vacuum trajectory, the right phaco energy to be reached and the set vacuum level to be reached. And then while separating, while cracking and separating, the surgeon has to be putting a very close watch on the eye of the tip, and the lens has to be moving as expected with coordinated movements of the foot pedal. So the right balance of the machine and the mind of the surgeon is so important. I'll demonstrate it with an action replay. Here the vacuum that is reached at a particular stage is set. That is the vacuum reaching 316 in this, holding it, and then the hand is twisting. This is to demonstrate the utility of this technique in a more difficult situation. Small pupil. Here it was not really twisting, but it was a pushing mechanism. This is active twist. Fine. Okay, thank you.
Third case being a mature cataract and much more harder. The movement shown before the actual entry. A relatively higher vacuum, higher power, burst mode. Second or third burst was applied.
So we are able to achieve more lateral separation because of the use of the bent
This is to
tip
complete
and the
the
twister mode.
revision.
The arm is pronated
Support of hand also taken.
at a particular stage to achieve the outcome.
When the vacuum is not sufficient or when the depth has not been reached at the initial stage, the process will not be as expected. We have to take more trials.
I think that was sufficient, sir. Thank you, sir.
Thank you. Nice demonstration to tackle the hard nucleus. Mohan Rajan.
Yeah, I think beautiful presentation, nice videos as well. I think three important parameters are necessary for all of us to know, whether it's beginners or even veterans. One is the vacuum. The vacuum is directly proportional to the holding power. If you want to hold the nucleus for more, for chopping, so you need to have more vacuum. Second is the aspiration flow rate, which can be adjusted in the peristaltic mission. The aspiration flow rate is directly proportional to the followability. If you want everything to come forward in a fastest pace, then you need to use more aspiration flow rate. The downside of using a very high aspiration flow rate is that your PC also will come forward, the iris also will come forward, all these problems are there. And third is the phaco power. The phaco power either can be continuous, burst or pulse. The pulse can be either regular or micro or hyperpulse or whatever it is which is part of the cold phaco system. These are three parameters which everybody has to know before they touch a phaco machine.
Yes, one more comment I want to make is that once we try to engage the piece, we can use a vacuum seal type of a thing. Initially, we may bury in the piece, because sometimes it does not hold.
Yeah.
Then we use a temporarily phaco to embed into the piece. Thank you very much.
Chopper,
Another trick is
Yes.
when it is not holding. See, normally the bevel is like this. Just hold this where the surface is more. Generally,
Yeah.
bevel is like this, na? Either this or this. You make into sideways. It gets large area of the adhesion. Definitely, it will hold.
Or I do bevel down, sir. If I'm using a straight tip, Kelman means I go sideways. If I use a straight tip, I go bevel down, and then expose the tip a little more. Okay, if you expose the tip a little more, then it will get buried into the, because these are all very, very thick nucleus. You can actually nicely bury, and so that you can get it. And keep the chopper right there.
Yes.
Don't keep the chopper near there, because you need to, you have only a millisecond for you to, that vacuum seal will be there. At that time, keep the chopper right in front and chop it as soon as you get the vacuum seal.
Exposure of tip is proportional to the hardness. If it is a hard, more exposure. If it is soft, less exposure.
One point I want to make, the aspiration flow rate and vacuum, they are directly proportional.
Yes, in a
So if we increase the aspiration, the vacuum also,
Vacuum also will
or vacuum hold will also increase. That's very, so we can increase the aspiration flow rate where we see less followability of the case. Thank you very much, sir.
Thank you, sir.
Sir, Dr. Lionel Raj is here? Dr. Lionel Raj? No. So I request Dr. Mohan Rajan, sir, for the discussion on Rexis tips and tricks.
Thank you very much, sir. Let me thank the AOS for this wonderful opportunity, and it's always a pleasure to come back to Vizag, and I have a lot of very good memories about Vizag as well. Yeah, can you take it? So I'm going to talk to you in the next 7 minutes about this Rexis tips and tricks, and these are my financial interests. So as you know, capsular Rexis is a continuous curvilinear capsulotomy, and you know the pearls are, you need to visualize, make sure that you have a good red glow. For example, you can see here, this is the needle Rexis I'm doing. So the most important thing is the needle Rexis, either you can use a needle or you can use a Utrecht forceps. The Utrecht forceps can be regular Utrecht or a micro Rexis or whatever you are comfortable with. Only thing is, make sure that your anterior chamber is always deep. A shallow chamber is the worst enemy for a capsular Rexis to go out. So again, very important, you can see this is called the, I am just pinching the Rexis. So this is called the pincho Rexis, I call it pincho Rexis. In immature cataracts, you can do that. So you can see here, I'm pinching the Rexis. Again, I'm making sure that the anterior chamber is deep. And if you are using a Utrecht forceps, every 3 clock hours, you need to shift your grasp. Okay, shift your grasp. Don't pull the thing, always go to the base of the, as you can see here, every 3 clock hours, I'm going to the base of the capsular Rexis, and then I'm pulling it from outside in. Again, very important. This is again another patient with the pincho Rexis. Since we have very little time, we will go through it very fast. So again, Rexis in PPC is very important. Why? Because you don't want to have a small Rexis, you don't want to have a very big Rexis. Why? Because if you want, if there is a pre-existing dehiscence of the PC, then you need to capture the lens, multi-piece lens in the capsular Rexis margin. For that, if you have a very large Rexis like 6 millimeter, you will not be able to capture it. So again, Rexis and PPC again very important. Small pupil can go to do the Rexis underneath the pupil. How do you do underneath the pupil? So underneath the pupil you do, I use usually Utrecht forceps, very difficult to do with the needle. Of course, you can do that as well. You can see here I'm following the margin of the Rexis underneath. So actually the Rexis size is bigger than the pupil size. So the pupil even comes down a little because these patients are all on Urimax and they may come down a little. Then it doesn't matter for you because you know exactly where your Rexis is and you can go ahead and do the vertical chop. Again, another patient you can see here how I'm trying to do the Rexis making the rexus bigger than the pupil. Very, very important for all of us, especially in the mid-dilated pupil. The small pupil, then you can go for iris expansion devices. Mid-dilated pupil, you can do that as well. So, escaping rexus, you can see there's a mature cataract. When it's escaping, here, stop. Here you just stop here because come out of it and then put in a viscoelastic. Preferably I use a viscoat. I don't have any financial interest. Then use a micro rexus forceps and try to pull it towards the center. Again, very, very important for you to understand this ball game. Again, another patient with the escaping rexus in the periphery, and I'm trying to, so whenever you have a escaping rexus, switch over from the needle to the Utrata. Why? Because you have Utrata, you have better control, and you will be able to get the rexus inside very nicely. Again, another patient, you can see here, this is a patient with a, this is a white cataract. The white cataract is always a challenge. The intumescent, the mature white cataracts, hypermature. The most common is the intraventricular pressure is very high in the type 1 white cataracts. You can see this is the patient. You can see that the Argentina flag sign has occurred. As soon as they touch it, it's going to the periphery. Okay? And this is one of the patients, you can see here what I'm doing is, this is another patient, you can see the type 1 intumescent cataracts are very dangerous because despite the fact I was using a viscoat for this patient, I was going, you can see that as soon as they touch it, it's going to the periphery. The problem is the rexus tear which is on the opposite side can wrap around the equator and you can lose the nucleus. And this patient was a union minister, and you know these politicians commit a lot of sin and they come to you, and the physician was watching through the side tube, and he wanted a multifocal lens. So what I did was, so I just tried to, fortunately for me the cataract is not a very hard cataract. If it's a brown cataract, probably would have converted. I could have just gone ahead with the phaco as well. But you can see here I'm trying to convert one part of the rexus into a semicircular rexus, the other part. I don't want any tags there. So again I'm making sure that I'm converting that one part of the rexus, and then I went ahead with the phacoemulsification. The preferred technique is a direct chop. I'm using my chopper, the Mohan Rajan chopper, which is made by Apasami. I don't have any financial interest. Again, just bring that nucleus a little up, because I don't want that any stress on the bag. So I don't mind losing some endothelial cells because I put some viscoat. Fortunately for me, as I told you, this patient had a grade 2 cataract and I was able to manage, but not a multifocal lens in this case. I put a unifocal lens into the bag. Again, this is a problem in the type 1 cataracts. See, the problem is there is a pressure underneath the anterior capsule. The nucleus is bulky. There is a pressure in front of the posterior capsule, and there is a positive vitreous pressure also. So if you put a needle, for example here, this is a 30 gauge needle, you can decompress the anterior segment. You can decompress the anterior segment, and you can, that is the first component you can decompress. But you are not debulking the nucleus. You are not taking care of the pressure in front of the posterior capsule, which is actually pushing the nucleus in these types of cataracts. So as see, you can get away in about 50 to 60% of the cases without any, or if you have access to zeptorexis. Only thing is, it's a very, it's an invasive technique. If you have a shallow chamber like a phacoemorphic glaucoma, or which I have access to femtocatalyst laser, this is a 100% foolproof method. This again, a patient you can see here. What you can do is in this type of mature cataracts, you can do a small rexus there, but make sure that you use a phaco probe and trench it. Because the nucleus is also bulky, you need to make a trench and then try to extend that and make it a little bigger. Obviously, you cannot, because this is a very hard cataract, you cannot do this with this small rexus. So I'm trying to, when you extend the rexus, make sure that you use a vitreous scissors and cut it obliquely, not cut it like this horizontally, because you can go to the periphery. Again, very important for you to understand. If you're going to extend the rexus, make it inside out. If you're going to make the primary rexus, make it outside in. This is again puncture rexus, which I have devised, has become very popular now. I'm using a phaco needle, beveled down. I'm using a 15 degree and just punching. See, as you punch, you punch not only the anterior capsule, but also debulk the nucleus as well. So you're able to, you can just put any viscoelastic there and you can go ahead. In this case, the rexus will not extend 100% and produce Argentina flag sign. You can again see here, I'm putting blue rex, and then I'm using just simple HPMC. No viscode, no hyaluron, because I don't want anything to occlude the tip and the anterior capsule. I'm going at and going all the way down in the fusage, just like you go all the way down on the accelerator in the car. So it's very important. And this puncturexis not only takes care of the front component, but also of the posterior compartment as well. I'll take another 30 seconds more, sir. Just to show you this phacoexis also you can do. With the phaco, it will, requires a little bit of learning curve. Again, the little rescue technique is something which you can see here. When it goes to the periphery, try to pull the rexis in the same direction as you are going. This is called the Brian little rescue technique. As you can see here, I'm trying to do that, and you can see that you can do this thing. Again, hydro rupture, very important. You can see here, I'm trying to do the hydro. See, notice what is happening. I'm not decompressing the nucleus, and notice what is happening. There is a rupture of the anterior capsule. This 100% will extend across the equator and go, you can lose the nucleus into this thing. Rexis started doing IA, rexis extended, and all these are very, very important for all of us. So thank you very much for the wonderful opportunity, sir, and the patient attention. If you have any questions, I would be willing to answer. Thank you.
Sir, excellent presentation. Sir, sir, I have one or two points regarding this. Generally, we should replace the aqueous with the viscoelastic before proceeding for the capsular rexis.
Yes.
That should be first for the post-residual tip.
Yes, sir. Yes, sir.
So the cannula should go to the opposite meridian and replace the aqueous with the visco.
Yeah, correct.
Number second is that we should do under high magnification.
Yes.
Rexis.
Yes, sir.
If we do in under low magnification, you may have some difficulties. Sir, number second, I want to know what, suppose we do a rexis by capsulotomy, then people shift to the forceps. There are some difficulties. Once they enter, there is a shallow chamber. Can you tell some tips how to learn the rexis by the forceps?
No, very, very easy, sir. Only thing, with the needle you can start and create what is called a guide flap. So the guide flap, either you can go to the right or you can go to the left, depending on whatever you are comfortable with, and create a guide flap. And then once you create a guide flap, then use a good viscoelastic to deepen the chamber and use the rexis forceps. Only thing is you catch the base of the rexis and not the tip. Catch the base of rexis and go around in a centripetal fashion so that you are always pulling towards the center. And whenever every 3 clockwise, as I told you, I demonstrated very nicely in that, you need to replace the gel and then go in and regrasp the flap at the base of it. Every 3 clockwise, you regrasp.
Forceps should not press on the wound.
Yes, absolutely.
That's important.
Yeah, you mentioned, yes, it's a very good point, because when you go in, normally the tendency for beginners is to keep press the forceps on the posterior lip. If you press the forceps on the posterior lip, what will happen is all the viscoelastic will come out and the AC will shallow and the rexis will go to the periphery. So you don't want that to happen. So always keep the forceps on the anterior lip. Keep it on the anterior lip, that is towards the cornea. You keep it and press it against the cornea, and then you'll be able to do it. Or you can go through the side port with a micro rexis forceps also.
Sir, regarding
to avoid all this, you start with the side port is capsulotomy. You always use a micro forceps. Forget about uterata forceps. You will like it, and there is no chance of chamber collapsing. Do with micro forceps.
Yes, sir.
Sir, I have a question.
Yeah.
When you're teaching your fellows for the first time, most I have seen you, you're doing your rexis anti-clockwise. So when you're teaching a fellow, because they do not know which direction is right.
Either is correct. Either one is
Yeah, that is fine.
But what is the ideal way to teach them? How will they know?
You ask him to try once right side, once left side. Which is convenient for him, leave it.
What I always told my fellows is, I asked him to draw a circle on a paper. So if he draws his anti-clockwise, that is the way he has to do. That is the most comfortable direction. If he draws it in the anti-clockwise, the clockwise, then that is the right direction for him to learn.
No, it doesn't matter, sir. Because as right-handed surgeons know because it's going anti-clockwise is a little easier than the clockwise. Doesn't matter. Many surgeons do that clockwise as well.
But majority do anti-clockwise.
Majority do anti-clockwise.
Majority do.
Yes.
Because the advantage of anti-clockwise is that the guide flap you can create much better because you are a right-handed surgeon, mostly, unless you are a left-handed surgeon, you create the, make that initial this thing on the capsule, and if you go towards the right and then flap it, okay, if you go to the left also you can do that, but the right is definitely more comfortable because you are a right-handed surgeon, no?
True, sir.
Sir, whenever there is a liquefaction within the lens, we will find it difficult to use the needle. Maybe at that time, either microforceps or the Rexis forceps may be the first choice itself.
No, you have to evacuate the liquid.
Yeah.
Evacuate the liquid thoroughly, then you can enjoy it because the tension is there, not there. Intralenticular pressure is gone once you evacuate it. It behaves as that of a normal case.
Yes.
Yeah,
Yes.
that's what I mentioned, no, the Puncturexis, why it works because you are using a bigger needle, bigger bore, for example, the Phaco. So it is able to decompress both the front as well as the back compartment, and because you are giving Phaco also, it debulks the nucleus and pushes it back. So all within a millisecond it occurs, because you don't give the time for that nucleus to come forward and open the rexis. That is why the Puncturexis, it's a very, just try it, sir, it's very easy.
Sir, one more point is regarding the hypermature, mature cataracts, the needle rexis becomes a bit difficult at times, even the fibrosed capsule.
Yes, sir, yes, sir.
So we should use.
I had some videos, but because of lack of time.
We should use the forceps.
Absolutely, sir.
In
Any
those
difficult situation, use the forceps.
Can you, sir, tell us about the shear and tear technique by using forceps? Shear and tear technique.
Yes, sir. The forceps, the advantage of the forceps is that even if the fibrotic capsule, you can go beyond that fibrotic area and come in that clear area, and you can go to the periphery also. The problem with the needle is that you cannot go too much to the periphery, and because you don't thing. Whereas in a rexis, it's not only shearing but it's also tears with the Utrata. So both the techniques, both the things are, the features are there with the Utrata forceps. That is the advantage, and you have better control.
Sir, I want to say that shearing you do a tangential this.
Yes, sir.
And tear, while you feel it is extend, you can tear it centripetally to bring it back.
Yes, sir. Yes, sir.
Thank you very much, sir.
Thank you very
Excellent
much. Thank you very much.
presentation.
Thank you very much,
Sir,
sir.
next I will call upon Dr. Akshay Goyal. He will speak on nucleus
Yeah, yeah.
management in soft cataracts.
Quick. Yeah.
When it is a Morgagni cataract and we are doing SSCS, what do you advise at the capsulotomy part?
Yeah, it's very difficult because when you have a Morgagni cataract, always you stain, that is one thing, and then you make a small
Envelope technique.
envelope technique and try to make, because you don't have the support underneath. Because the nucleus is small, you don't have the support underneath. So again, I would prefer to use a forceps for this. I use a good, something like a shaft shell technique, which has been described by Steve Varshinov, both viscoat as well as hyalon. You put it so that you inflate the anterior chamber very nicely. You also protect the endothelium and keep the anterior chamber deep. And you can try that as well.
Like what you said is should be done after removing the fluid, sir. What I generally do is I give a small nick with my 26 gauge needle in the center. I
Then
aspirate
use,
whatever fluid
saline.
is coming out. Then make the capsule flat with the visco and then start doing the.
Yeah.
Fine,
The
fine.
saline has
That's
to come
fine.
out. Yeah.
Using the
Yeah, I
Rexis
had some
forceps.
videos because of lack of time. I couldn't show that. Yes.
Thank you, sir. Thank you, sir. Dr. Akshay Goyal is here. Please.
Is there? Yeah.
Dr. Akshay Goyal, he will speak on nucleus management in soft cataracts.
Good morning, everyone, and thank you for this opportunity. Today, we will be taking up the extra soft nucleus challenge. And with this video, I will say challenge accepted. So here you can see we have performed a 5 to 5.5 millimeter rexis. A young female, around 22-year-old, came with this cataract, and the nucleus was really soft. So I went in with an irrigation and aspiration cannula and tried to debulk the nucleus because trenching was just not possible. So after performing some debulking, we went in with the Phaco probe and then tried to get the remaining of the nucleus out. And as you can see, I tried to do this swiveling motion upwards and catch hold of the nucleus and bring it into the anterior chamber with the Phaco probe. And once we realize that it's not coming out even with the Phaco probe, we can do a visco expression and by injecting visco, the soft jelly-like nucleus is then expelled out from the anterior chamber. This is another case, this is very interesting, around 50-year-old male with this very soft cortical cataract. I tried to do trenching, but it was very difficult because it was very soft. So even though we managed to make a trench, but the chopping was just not possible. As you'll see here, I tried to hold the nucleus, but the hold is not good enough to perform a chop. So I try to rotate the nucleus again, get to an area where I can try and perform a chop. Here you can see it was a failed chop. I tried to chop, but it just did not work. I grab the nucleus again from another edge, keep rotating it and trying to grab it from the adjacent edge and try to chop it. But it just doesn't work. So in this kind of case, it is very important to be patient. I then try to deepen the trench a little and slowly try to get an edge to chop the nucleus. But as you can see here, it does not work again. So after performing all these maneuvers, I then decide that I have to try and chop again, and after several failed attempts, you can see that it is getting a little frustrating. I've tried many times. I even catch hold of the nucleus this time. I tried to chop, but again it did not work. Another thing to notice is that I never go beyond the rhexis margin and stay well within the rhexis margin to ensure we don't land up in some kind of trouble. Every time I try to chop this nucleus, it just doesn't work. It fails. It either cheese wires through the nucleus or the vacuum just lets it go. Finally, I managed to get a bit of a grip on this, and with this swiveling motion again upwards, I tried to bring the nucleus into anterior chamber. I managed to bring some of it into the anterior chamber, and with the phaco probe, I tried to bring as much of it as possible into the anterior chamber. The moment I try a chop, there again, no grip, and then some part of the nucleus is gone. But thankfully, this is slowly leading to debulking of the nucleus, and eventually I managed to get more grip into it and slowly bring the small nucleus into the anterior chamber. I have to keep injecting viscoelastic again and again to ensure that the anterior chamber is well maintained. I again try to make a chop, get some grip on the nucleus, but it just doesn't work. And as you can see here, again sticking well within the rhexis margin, I try to get a grip again. It keeps rotating. I keep getting a little bit of grip on the nucleus, but it just does not come into the anterior chamber. So now what we are left with is a very uneven shaped nucleus, which is just very friable, and it is coming out in bits and pieces. We have to be very sure about our phaco parameters, use low phaco parameters, mostly in vacuum mode. And finally, once the nucleus is debulked enough, it is small enough, it comes out into the anterior chamber and then managed to finish this case. So it was challenging, it took time, but yes, success achieved. You can see this is a very dense PSC case. I've managed of around 5 to 6 millimeters rhexis, and after performing the hydrodissection, we go in for trenching. I tried to trench, but no, there was just not possibility to chop. So again, with this swiveling motion, I try to hold the nucleus with the vacuum and bring it up into the anterior chamber. Slowly you can see the nucleus is coming into the anterior chamber. We have to keep injecting visco repeatedly to bring the nucleus into the anterior chamber. So I've managed to get half of the nucleus out, and as you can see, the consistency is just like jelly. It is very soft, and it is just not possible to do anything with the second instrument or get any kind of grip to chop this. So again, I do this swiveling motion. As you can see, this upward swiveling motion slowly gets more grip on the nucleus, and slowly it comes out into the anterior chamber, and once it's out into the anterior chamber, we are able to perform the phacoemulsification. So patience is the key here. We have to be very sure of our phacodynamics. We have to stick to the basics and use viscoelastic judiciously to maintain the anterior chamber well. We can also try changing the second hand instrument to a larger dialer, which can give you some more surface area to do the chop. Never cross the rexis margin with your phaco probe, because if we go too much into the periphery, there is possibility of some kind of complications. And low phaco parameters with more vacuum mode has to be used. Thank you.
Oh, wonderful presentation, Akshay. I think you highlight a very important problem which we are all facing now, especially patients coming with 6/9, 6 vision we are operating. These are cataracts, I call them NHNT. You know, neither here nor there. Okay? These are in-between cataracts. Very difficult. They don't suck, they don't crack, they don't chop. So, very difficult. And if you try to create a vacuum seat, it will cheese wire and go to the periphery as well. And it's very quite dangerous. You can't use very high parameters. So what I do is, I'll take the opinion of the panelists as well. I make a very narrow, deep trench for these patients. Very narrow. It should not be very broad. It should not be. It should be less than 1 phaco tip width. Less than 1. Normally it's 1 or 2 phaco tip for harder cataracts. Harder cataracts, very what Ravindra has shown, beautiful. You can chop because the hold is there. Soft, very soft cataracts on this side, a spectrum, you just make a slight rexis, do a hydrodelineation, hydrodissection, the whole thing will come up and you can aspirate the whole thing. But these are cataract very. So I make a very narrow trench, deep trench, and then try to separate and do what is something like a stop and chop technique. What's your take, sir?
My thing is,
Yes.
I always go for 5 mm rexis only. I will not go to the larger or smaller. So, hydrodelineation, hydrodelineation, hydrodelineation. 2, 3, 4 times I try. So, naturally this hard central part will come out into the AC. That is aspirated with the phaco with no energy. The rest of the epinucleus, I prolapse it with visco. Instead of hydro, I pass the visco underneath the anterior capsule. It goes back and it prolapses the soft epinucleus out. Within no time, you can finish the job and a highly safe manner. One is hydrodelineation. Second is visco expression or visco prolapse of the epinucleus into the AC.
Good tips about management of the soft cataract. One more thing we can do, a hydroprolapse. Hydroprolapse of the soft, in soft cataracts is a very easy thing.
No,
to
sir.
do.
These are all, you're right, sir. These, cause that is the one end of the spectrum, soft cataract. These are cataracts which are, I told you, say in between. They are neither soft, they are neither hard also.
For in
That's what he has
between,
shown.
your technique
It's
is
very
better.
difficult, sir. And this will occur in a VIP patient. Somebody is watching through a side tube, he will struggle. Okay? And this happens very commonly. This happened for me, it has happened, I'm going to happen for everybody. Okay? But these are cataracts, very difficult, even if you do hydrodelineation, it will not come up. Okay? Because they are not soft. They are neither soft nor hard. So, my take home this, what is your thing, Ravindra?
Whichever settings I am using for the quadrant removal will be the ideal for me rather than using the settings for the chopping. Division is no longer required. So this appears to me to be better tackled by the quadrant technique. And usually it will be having lower vacuum, lower, slightly more flow rate. So it is supposed to be aspirating.
Something like epinuclear mode.
Yeah, epinuclear mode, sir.
So we
Yes,
have
sir.
different techniques. One is a small trench, other is the hydroprolapse, and third is that you can do a chopping type of method. But most important, I think, while doing a chopping, should not be doing like a hard cataract. You don't have to apply phaco power. You have to be in vacuum only. If you apply phaco power, it gets chipped off.
Yes, sir.
So better to hold it with vacuum only and then chop. I think that's
Yeah. Chopping without use of vacuum, without use of phaco.
The problem is, sir, when you hold, see, what do you hold? That's the problem. Because if it's a hard cataract, you can hold something, sir. Here, if you try to put a vacuum there, about 400, 500 or whatever it is, then it will cheese wire, it will go.
Immediately.
So you will not have any grip for you to chop. So these are cataracts with neither crack, neither chop, neither suck. So that's a problem. Yes? Mic is on, mic should be on.
Yeah, it's on, yeah. So when I was watching Akshay's video, at one point of time, you actually could remove the peripheral part of the nucleus, right under the rexus. So that is the most ideal situation what I would look for. So once you get that part, all you need to do is maintain the AC either with the viscoelastics or with your phaco probe. Maintain the anterior chamber, just put your dialet down there and just lift it up. The entire thing is done. The only thing you were struggling with the phaco probe trying to remove what is in the back, but you almost removed the central part, so you debulk the central part, and the peripheral part you had a nice hole there so that you can just put a second instrument and lift it up. And the entire thing becomes very easy after that. That's what I generally do. So what I generally do is
I tried all of that actually. I edited it out in the video, all the struggle actually.
So
I tried all that, but it was not working, so I had to continue slowly with
for me,
that
when
way.
I do
I agree with your point, and that can definitely be brought out using the second instruments, but sometimes that also just
Thank you,
doesn't work.
Dr. Akshay. We are running short of time. Very good
Thank you so
presentation.
much, sir. Thank you so much.
So next, I will call upon Dr. Spurti. She will speak on different ways to bear less soft cataract.
Sir, Raikumar Reddy, sir. Sir, I have a small doubt. When I generally only do small incision cataract, sir, at a setup. The difficulty what I generally face is when I complete my hydro, I generally get the nucleus and epinucleus, and that sheet of or the cup of the cortical matter is left over intact, and my Simcoe cannulas doesn't support me in pulling the total cup of the matter. So can I repeat this hydro or the visco again to get that cup of matter into the AC?
Any number of times you can repeat.
Like
Any
without the
number of
support of
times.
the nucleus, can we repeat again the hydro
Oh,
or
yes.
the visc, sir?
It is easy without nucleus. You can repeat the hydro procedures, you can repeat the visco procedures.
We can repeat many times. There is no problem. Next presentation, please.
Yeah, good morning, everyone. Good morning to the panel and AIOS. I'm so happy that half of the discussion is already done about soft cataracts. So my topic will be a continuation of the previous talk probably. So I'll be talking about different ways to handle a soft cataract. So why this topic? Because nowadays young and more younger people are becoming more aware of the cataract and they're getting the surgery done. And if something goes wrong, you have to bear the grunt because they are going to live for many more decades. And it has become a refractive procedure long back, and soft cataract can give you a hard time. Why is it difficult? Just like Mohan Rajan sir was saying, it doesn't chop, it doesn't crack, and power play becomes more detrimental in a soft cataract. It's always good to avoid torsional energy, and foot pedal control is of course important in any cataract, but it becomes more so, all the more important in a soft cataract. So 7 techniques in 7 minutes. I'll be talking about this 3-decade-old divide and conquer. It still holds very good. Just as sir was mentioning, a deep trench. How is it different from a normal hard cataract trench? There should be minimal power. You have to initiate the trench with only half the tip occluded, go very slow, and the procedure has to be very controlled. And the depth of the trench should be guided by the red glow. Don't do too much of a trenching. When you can see little more red glow than the other part of the heminucleus, then you can stop the trenching. And you have to put your 2 instruments at the depth of the crack. What happens if you put them little superficial? You'll end up creating a bowl. So you have to put the 2 instruments, just like in the video. You create a narrow trench, crack them, and then each heminucleus can be easily handled, just like any other quadrant. So then the next technique will be delaminate and conquer. I named this technique because I felt this is the apt description of the technique. I did not find this term in literature. So this is a case of a posterior polar cataract, probably grade 2 or grade 3. I'm avoiding a hydro dissection in this case. I straight away do a hydro delineation. Once I do a hydro delineation here, I'm mechanically separating the endonucleus from the rest of the epinuclear cortex by passing the cannula underneath, the same hydro cannula underneath, and the chopper. So once I do that, the endonucleus is quite free to be handled. See, it so effortlessly comes into the phaco probe, and then the rest of the nucleus also has effortlessly come down. The best part is there's no dehiscence here because it was probably a grade 2 or grade 3 posterior polar cataract. So I then remove the phaco probe after injecting visco, not to create chamber fluctuations. And then next technique will be delaminate and endochop. So the most important part is to delaminate all the time in a soft cataract. So once you delaminate, it is very easy to handle the endonucleus and the rest of the epinuclear part. So here, the prerequisite is always a good 5 to 5.5 mm rhexis. Do a hydrodissection, get that good golden ring of hydrodelineation. Remove all the epinuclear cortex, because just like blood in any other surgery, this epinuclear loose cortex is what causes all the confusion. So clear that. Once it is clear, the endonucleus is separate, you can just chop the endonucleus. Do not go till the periphery, only the endonucleus can be chopped, just like a direct chop procedure. Then the other procedure, which is again age-old one, is flip and chip. So here, as Ravi Kumar Reddy sir said, you get as many golden rings as possible. You do once, twice, thrice. Here you can see 3 golden rings here. I did 3 delineations probably. So the smaller the size of the ring, it means the endonucleus is quite small. So clear the epinuclear cortex. Go in with the phaco probe and clear the epinuclear cortex. The whole procedure has to be quite controlled with modest parameters in a soft cataract, unlike in a hard cataract. Once all the epinuclear cortex is cleared, you can see already the nucleus is ready to come into the phaco probe. It starts crumbling because it's quite soft. So you prolapse one pole of the nucleus out of the capsular bag. And then if it's hard enough, you can do a chop, or if it's very soft, you can do a chip. So it's just called flip and chip or a flip and chop, depending on the grade of the nucleus. So once it is done, the rest of the cortex can be easily aspirated. Then the supracapsular technique, though this is not my personal favorite, but probably this can be done when the zonules are compromised, or the surgeon is a trainee surgeon and you want to really protect the capsule. But this becomes, or in a myope case, in a high myope, when the AC is very deep, you can follow this technique, but this becomes a little difficult in short eyes. So this is a supracapsular technique. Just like in SICS, you do a dissection and a hydrodelineation and then prolapse the nucleus out of the capsular bag. Once it is done, you can just handle the nucleus like any other quadrant. And the rest of the cortex can be easily aspirated because the hydrodissection is already done. Then the carousel technique, this is becoming recently more famous. Do a good sized capsulorhexis, a good 5.5 mm capsulorhexis. Do a good hydrodissection and a hydrodelineation. If you see the golden ring, then you can give a nice rotation in both clockwise and anti-clockwise directions of the nucleus. Once you delineate the nucleus, you clear off the epinuclear part. Just at the edge of the nucleus, you create a gutter, create a little, clear off the epinuclear part at the edge of the nucleus by creating a gutter. Then you impale the phaco tip towards the nucleus, then it lifts up a little bit. Then with increasing phaco energy, you can rotate, it keeps on rotating and comes into the phaco probe like probably a bhuchakram or a carousel technique. Then once it is done, you can clear off the cortical part. Then the zero phaco technique, if you can see this case, this is a very young patient you can also make out from the thick eyelashes, thick black eyelashes and the eyebrows. So this is a young patient with only PSCC and 6/9 vision. Make a good 5 to 5.5 mm rhexis, do a hydrodissection and a delineation. I'm passing my hydrocannula underneath the nucleus. You can see it's quite clearly seen because the nucleus doesn't have much density. So I go in directly and then create one more layer under direct visualization. You can see one more fluid wave there. This is almost like Vasavada sir's inside out hydrodelineation. You delineate you decide the depth and decide where the fluid wave is passing at which plane. So, and then you remove it quite effortlessly. As you can see in the inset, it's always 0. The power is continuously being 0 here. And then the next slide, to summarize, do a good hydrodissection and a delineation. The first technique, divide and conquer, do a good trench and divide. The delineate and endo chop, you just delineate and do a direct chop only on the nucleus part.
Dr. Kindly conclude.
Sir?
Kindly conclude.
Almost at the end, sir. 1 more minute. The carousel technique, you create a gutter and then it keeps up rotating. What can go wrong? So this is one more patient related to me, but that's not the problem. She's also related to one more popular politician. Do a good rhexis. I was planning to do a direct chop in this soft cataract. I didn't do a hydrodelineation because I was confident that I'll do end up with a direct chop. But what happens, I could initiate a crack, but if you can see, I was it's getting eaten up because it's too soft. Then I finally ended up with a bowl here. See, what I'm left with is just a bowl. What I did, I introduced 2 instruments into the AC. I could separate them mechanically and then eat them up. So there can be special situations like posterior hyaloid artery. This can be skipped. So always go big on the rexis size, do good hydrodissection and delineation. Always have a plane of fluid around the nucleus because it gives a cushion from going right into the capsule. Always do surplus hydrodissection, do surplus rotation, find the sweet spot in the foot pedal where there is a good balance between your vacuum creation and power delivery. Always listen to the machine, less power fetches more, delineation, delineation and delineate and conquer. Thank you.
Thank you very much.
Thank you. You mastered the soft cataract. So I agree all these procedures.
This is Otley. All the videos are from Otley.
Dr. Sandeep,
Yes, sir.
Yeah.
I have one point regarding the supracapsular technique. You should coat the endothelium well before
Yes, of
proceeding
And
for the
also
treatment.
your energy keep at 10.
Yes, sir.
Energy only 10.
Yes. In
You
fact,
can
in all
enjoy.
the cases.
You can enjoy supracapsular. Your aim is to aspirate, not the phaco.
We go now to the other spectrum, hard cataract, dig and burrow, my technique.
Good
Dr.
morning,
Sandeep.
everybody. So, as you all know, the hard cataracts have always been a challenge. So, hard cataracts are very common in diabetics, pseudoexfoliation, very hard mature cataracts, brown luminescent cataracts. If you're looking at one of these, my very old videos where I started doing hard cataracts and my technique was not, I was not very comfortable. So, after a good hydrodissection, the major problem with operating hard cataracts is once you chop, the chop does not extend up to the posterior part of the nucleus. So it is very difficult to chop the posterior fibers, though you will be able to do chop the anterior fibers. So the basic problem is chopping how do you do that is you have to debulk the nucleus in the central part as much as possible and hold the nucleus as deep as possible to get a good chop of the posterior plate of the nucleus. If you look at this case, I could do a part of it, but later on the pupil becomes small and the chopping becomes so difficult that I'm not able to remove the posterior plate. So finally what I had to do is I had to extend the nucleus, I mean the incision, and then I had to remove the nucleus. This is like way before I started doing the technique. So this is my dig and burrow technique. The rexis size remains almost the same as 5.5 rexis size. I don't change the rexis size. And the hydro procedures remain the same. You do a good hydrodissection. Only in the, just stay in the rexis area and don't extend too much. So what I do is, initially we do a very good central trench. That means make a central burrow, a deep burrow like this, as posterior to the as posterior as possible. So once you use the maximum power possible, generally I use the maximum torsional power and make a very good central trench. So this is what I call is the central dig. So dig the central part as much as possible, so that what you're trying to do is you're doing you're going as deep into the nucleus as possible. Once you do that, you make multiple burrows like this. This is the first burrow, the second burrow, and then in the third burrow, hold the nucleus and then chop. So what you're doing is you're debulking the nucleus. So that's the first burrow, this is the second burrow, and this is the third burrow. Once you do the third burrow, hold the nucleus there and then crack. So by this, you can actually almost reach to the posterior plate and you can almost have a complete chop. So second burrow, this is the third burrow, and now the third burrow, and hold the nucleus with the maximum parameters with high vacuum. And you can have a complete chop. The basic advantage of this technique in comparison to what Dr. Ravindran sir has done is, Ravindran sir actually takes the chopper way beneath the capsular rexis, and from the equator he chops it. So basically, in this technique, you can still stay in the rexis margin itself within the pupillary area, and then you can actually chop the nucleus. So once the pieces are separated, then you can use the soft shell technique, where you coat the endothelium with viscoat, and then, so I have used the viscoat. So and then you can actually once I don't use the second instrument after I have chopped all the pieces. So what is the most important tips in this technique is, you should have a good exposure of the phaco probe, at least of 2 to 3 mm, so that the sleeve does not stop you from embedding into the nucleus. If the sleeve is too anterior, then the tip may not actually embed into the nucleus. The central dig should not extend into the periphery. Make as many pieces as possible, and the soft shell technique is compulsory. So it is its advantage of vertical direct chop can be done in small pupils, and chances of breaking the rexis is very less, and there is no undue pressures on the zonules. Thank you.
Wonderful technique. I think, are you using my chopper?
Yes, sir, that's your chopper.
You didn't mention that. You have to pay some money for that also. Yeah, you're not giving me any my loyalty for that. Whatever it is, a beautiful technique. Vertical chop is the way to go in hard cataracts. Horizontal chop, you can do that. Only problem is in the vertical chop, in the horizontal chop, because these are cataracts which have got nucleus and more nucleus, and there's no very little cortical cushion there. So horizontal chop is from the equator. So vertical chop is right in front of the rexis. Horizontal chop is a little blind technique. Vertical chop is directly under a direct visualization. So we use a sharp chopper for vertical chop.
I think for the vertical chop, that you have to hold the nucleus and bring it slightly anterior, and the other instrument should put pressure down, and the handpiece should put pressure up.
Yes, sir.
Then it has.
And also, sir, what I would suggest is, when you use your vertical chop, go into the body of the nucleus, tilt your phaco probe slightly like this, not go tangential to the capsular rexis margin or parallel to the capsular rexis. Go slightly down into the body, because these are all very thick cataracts, about 4-5 millimeter more. So you can go and nicely bury and do a vertical chop. Lovely videos, Sandeep. Fantastic.
Good, excellent presentation.
Yeah, I think we should go to the final talk.
We will go to the next presentation because we are running short of time. I will call upon Dr. Ilan Kumaran for his talk on future of IOLs.
Thank you, sir. Good morning, sir, all of you. At the outset, I would like to thank the scientific committee, APAO, for providing me this opportunity to address a gathering, such an august gathering in the presence of very experienced surgeon. The goal of any surgery in the eye, is to provide good functional vision for all distances. Not only this, patient should be satisfied and there should be no dysphotopsias. So everyone has spoken about the surgical techniques. I'm coming into the IOLs, not what we have now, but what we are going to get in the near future. As regards what an IOL should correct, it should correct all these things. And last one, what I would like to say is one lens custom solution, so that we don't have different types of lenses, different types of injectors. One lens to do it, but no company is going to bring it, so I've removed it. They want their money. Now, as regards what the lenses are available, to most extent, we have almost conquered astigmatism, myopia, hyperopia, given premium vision, and then almost treated presbyopia. I said almost treated presbyopia, but then are we complete in that? So these are the two techniques what I'd be talking about. Number one, if we create any refractive error, if there is any residual error, we should be able to treat it. That is, it should be reversible. Number two, by final frontier for any refractive surgeon is presbyopia, how do we do it? We have enough number of toric, multifocal, trifocals, toric, multifocal, trifocal lenses which give clear vision. But then is the patient happy? Does it give the vision of a teenager or at least of a person who's less than 40 years of age? No, the answer is no. While monofocal provides distance clear vision, Bifocal and trifocals to a certain extent provide near and intermediate vision, but not that crystal clear vision what we used to have. Invariably, a patient has all these things: glare, halos, loss of contrast, quality of vision is affected, and he is dissatisfied. Thanks to all these rings or the other things what we are creating. If not the rings, we are at least creating a spherical aberration there and then improving the depth of focus. Hence, even with the extended depth of vision lenses, monovision lenses, we have some amount of dysphotopsia. An ideal IOL should be like this: crystal clear lens with all the distances. So what are the options that are coming up? Number one, we'll talk about the reversible options. Simple option. Have two different separate haptic and a separate optic. Take it inside and lock it. Simple, right? But it is difficult to remove this optic. This is one of the options that's coming up. Instead of that, what is exciting in this group is to fill the capsule with an artificial capsule. It's called an Omega Gemini capsule. Put it inside and then place the lens. What this artificial capsule does is, it inflates the bag so that it doesn't allow it to become fibrosed, and the lens is in place. So if there is an error, if the toric lens is not sitting in its position, we can always change it. These are the two reversible options coming out. This particular one, no clinical trials have been done, but then looks exciting. He is the inventor of this capsule. Now, as regards presbyopia, now here you can see that this is a combination of the previous one what we are talking. There is an artificial capsule that is placed, and there is a dual optic lens that is there. Clinical trials have been done, only the pilot trials have been done, and that's what has been noted. Good depth of focus as compared to a monofocal vision, good vision so that the patient is satisfied with very little dysphotopsia. Effectively what it does is, the lower part corrects most of the power, the upper part, the anterior curvature changes utilizing the ciliary body contraction, our own accommodation, and then apparently it gives the depth of focus almost 3.5 diopters. That is what it is giving. The third option is, why not replace it with two different liquids inside? How do we place it? That's something still they have not released it. A higher refractive index, heavier liquid at the bottom, so that when you are looking up, that comes into play and this corrects the distant vision. A lower refractive index, so that when we look down, this goes behind, and because of two different refractive index, the power changes. Both these have not yet come into clinical trials, but look exciting. Now, this is another lens, something based on similar model, wherein there are two different components. The haptic component has some fluid, which, when accommodated, pushes the fluid inside into the central component, changes the curvature of the central component. That is optic. You can call it entirely optic or whatever it is, but this is how it works. Clinical trials, clinical trials have been done. In fact, Alcon has purchased this company, and probably, if it is successful, we may be seeing it in the near future. No rings, good vision with most of these lenses. Now, what is really available right now are these reversible lenses. Many of you would have heard about it. A simple cataract surgery, low stress, simple surgery. Do the post-operative refraction, preferably at the end of 6 weeks. Look at that refraction, feed it into the machine, and treat the lens. What does the machine do? The lens is a silicon 3-piece lens. The machine changes again the refractive index, changes the curvature of this lens, and then for an hyperope, if by chance the person is in hyperope, then it increases the curvature, and if the person is a myope, decreases the curvature. Also, cylinders have been treated with it. This is not only clinical trials, it's available in the market in US also. Any day it may come to India. However, this does not treat presbyopia, it is reversible. So, certain, sorry, I would like to skip this slide. Certain good changes are happening. Here, this is a hydrophilic lens, wherein the lens is inserted, and after that, after 6 weeks, whatever necessary correction is done within the structure of this lens with the help of a femtosecond laser. You can see that the artificial multifocality has been created. So, we have been able to provide answer to presbyopia near close to the refractive correction what this patient might require post-surgery. Is it reversible? Yes, it is reversible. In case the patient is not happy, just reverse that. Now, what is more advantageous? If the patient still wants back his multifocality, you can still create it. This is the advantage. Now, what is the status of, how does this work? This is called a phase-wrapped structure. Inside two different refractive indices, if you create these kind of increase the refractive index and create a multifocality, what you normally create in a normal lens, 0.4 diopter change, gets converted into almost 3.3 diopter change. That's how it's successful with such low quality of change. Yes, sir, last minute, I'm almost in the last. So it changes the local refractive index. What is the status of this? Still not tried in humans. However, rabbit eyes, this is the thing. Targeted refraction, what was intended, what is actual, almost close. So it has been successful there. It has to come into the electronic IOLs. They came, they went, not much about it. But if there is one dream IOL I would like to think of, maybe place an IOL, something like a Google lens, so that you can see, you can make whatever, like the Google lens which had come in, it went out of focus. That's a dream. Thank you for providing this opportunity.
I thank all the speakers and the panelists for the wonderful session. Thank you. We'll have a group photograph. All the speakers are there. We can go down and take.